Great stuff. So yes, the idea in terms of our organisation, ours is a user-led organisation. So over 80% of our staff also have ADHD, or autism, or dyslexia, or dyspraxia, or a combination of those things. And as an independent user-led organisation, we are able to provide in Liverpool a unique lifespan service for all, for the whole family, from birth right through to old age. We provide training right across the UK, both for health professionals and for educational professionals, but we provide this unique lifespan clinic here in Liverpool, which is very much a test bed for innovation and research. And the idea is that if we are going to ask government to provide better services, then we want to be able to demonstrate ourselves how they can be done in a more effective way and in a cost-effective way. So it is quite a unique service in the UK. And for that reason, obviously, there is a great deal of attention focused on what we are doing. But I need to actually really make this point. And it's from the perspective of a neurodiverse evolutionary paradigm, and how we have addressed the issue of stigma and stereotyping, and how that is negatively impacting on healthcare services and education services, is to really make the point to the British government that if 1 in 5 human beings are neurodiverse, in other words, if 1 in 5 people have either ADHD or dyslexia or autism or dyscalculia or dyspraxia, then maybe we should begin to look at this from a different perspective and view this 20% of the population as being part of the diversity of human neurocognitive capacity by design. That there are too many people who are neurodiverse for this not to be part of evolutionary design. And therefore, does that challenge us to ask ourselves, should we continue to look at people who are neurodiverse as errors of genetics or disordered? Now, I make that point not to dismiss or deny in any way how difficult and challenging and impairing having these conditions can be. However, if we think about our medical language, and if we think about the culture within our education system, so much of how we define and view individuals, children or adults who have ADHD is from a deficit perspective. It is often about what people cannot do. It is about all of the disadvantage, difficulty, to the point where often we are not seeing the human being, we are only seeing a diagnostic label, and that diagnostic label has culturally created a phenomenal amount of stigma and stereotyping, so that when children or adults in the workplace are seen for the first time, but we see this label, it immediately conjures up a great deal of discrimination and exclusion. So what we're saying here is, maybe we need to start taking a more strength-based approach, and maybe we need to start challenging a lot of the enduring myths and stereotypes about ADHD, and recognize that we are talking about a human being and not simply somebody solely through the lens of a diagnosis. So if we can do that,
počistio sam, sredio sam kuću pa ga palim malo po malo.
Can Sasa mute his microphone?
Ideja da ispred svoje rođene kuće.
Say again, can you hear me?
Sasa, can you mute your microphone?
Yes, yes, wait.
Thank you. So what we are saying here is a more strength-based approach and educating everybody to accept the fact that if 1 in 5 human beings have a neurodevelopmental condition, we must start to view those human beings as a necessary part of human evolution and stop discriminating against them particularly from the day they start school, because we have had a significant reaction from young people here in the UK who are saying to their teachers, just because I have ADHD does not mean I am low ability. It does not mean that I am not intelligent. It does not mean that I am not employable. And therefore, if you understood how the human brain works and the whole diversity of learning, and understood that some people do have brains that are structurally and functionally different, that being different does not make me disordered or does not define me as having something wrong with me, something that there is lacking or something missing. Now, again, making the point that that does not deny that when we talk in medical language about the word disorder, disorder is a threshold by which in medicine we define somebody as being significantly impaired. And what we are saying is, if we identified ADHD much earlier on, if we had more information and understanding for parents so that they could better understand and meet their child's needs, if school teachers were better trained to identify these differences and make sure that those children are given the right support and the right kind of teaching to reduce the learner anxiety that often results in behaviors that are inappropriate for the classroom, but can also increase the risk of anxiety and depression, because children every day in school experience pervasive levels of learner anxiety. That if we address the systemic issues, supporting parents and educating parents, educating teachers, and educating all health professionals to see ADHD not through the lens of a diagnostic label, but through a more holistic and person-centered perspective that embraces an evolutionary understanding of why ADHD exists, in the same way that we have to accept why dyslexia exists, and Asperger's and dyspraxia and so on. And equally, moving away from this linear concept of mild, moderate, or severe, and understand that comorbidity is the rule rather than the exception, and understand that if all these people have these differences and that many of them have co-occurring neurodevelopmental conditions, that perhaps we need to think of this neurodiverse mind as being a bit more like a graphic equalizer that has multiple settings on it that relate to different types of brain function. And some of those settings are fixed genetically, but other settings on that scale are movable, because that is the impact of the environment in terms of how ADHD presents, both in the moment and from a maturational point of view across the lifespan. So not linear, but spectrum, and also frequently co-occurring with other neurodevelopmental conditions. And one of the issues that's really captured the the UK, in terms of challenging stigma and stereotype, is that industries, particularly major growth industries like Apple and Microsoft and Google, etc., have been actively recruiting neurodivergent employees for over a decade. And these businesses are recruiting people who have different minds, because they are saying that any successful business or organization will never innovate or change if everybody who is making the decision all has exactly the same mind and exactly the same perspective. And what we're also seeing is research that says over 35% of entrepreneurs have ADHD or dyslexia or both. So what is it that our industry is seeing that our education system is not? And that even some of our healthcare practitioners are not seeing, because again, we have for too long been stuck in a model of psychiatry where we are viewing solely the pathology rather than the potential. And this has actually caused the British government in the UK to introduce training for all its government departments on the very concept of neurodiversity, so that we can understand, recruit and support employees and not deny them those opportunities based on very outdated, negative and deficit-based perceptions of this medical diagnosis that we call ADHD in the UK. So I don't have to go over this. I know that you're all acutely aware of the disadvantages, the etiology of ADHD, its global prevalence, why there are certain risk factors like premature birth that can trigger that genetic potential. We know that there are shared genetic risk factors with autism and of course dyslexia, etc. We understand some of the differences in terms of brain function and brain structure. This we know. But in terms of the positives, we often don't describe the positives. And this is one of the reasons why mental health distress is much more common in people with ADHD, because the exclusion actually begins when a child starts school. In the same way, if I can just draw the analogy, for those of you that wear glasses, if you had to take your glasses off, would you ever have been able to do your job? Would you be able to read? Would you be able to have a career? And for those of us who wear glasses, if we didn't have the glasses, no, we wouldn't. We do not think of it as something particularly extraordinary that we can wear eyeglasses that will not remove the impairment, but will actually, when we're wearing the glasses, enable us to see properly. When it comes to ADHD, all too often, particularly in schools, we don't identify when a child has a cognitive impairment, because an assumption is always made incorrectly that every child is starting school with the same degree of neurological maturation, which we know is not the case, or that every child understands what instructions they are being given in the classroom. And the reality is, if they are neurodiverse, if they have ADHD, then they probably won't. But that exclusion starts very early on. And often we don't identify children until they're in their teens, when they've already experienced many years at school suffering from pervasive levels of anxiety, which significantly increase the risk of their mental health problems. So how are we addressing this? Because we know that there are many people who lead happy, healthy, and successful lives with ADHD, and then there are many others that don't. So what are the significant factors in changing the outcomes? And those significant factors are how we support families, how we identify those most at risk of ADHD from the day that they are born, how we change the culture in schools, and how we challenge a very outdated notion of what intelligence and ability is so that it is relevant for the 21st century and relevant for 21st century children. And how do we also then begin to challenge this ingrained cultural kind of concept of ADHD within the medical profession that sees it very much from a deficit-based perspective. And in the UK, while we acknowledge all of this, what we have begun to understand is we have got to take ADHD out of psychiatry and make it part of the national conversation for parents, for teachers, and for other health professionals, so that they understand that if 1 in 20 people are affected by ADHD, then it's everybody's business to do something about it and everybody's business to know something about it. It is not something that we leave to psychiatrists. So again, what we're saying in the UK is 7 out of 10 children who are permanently excluded from school are children who have neurodevelopmental conditions, 7 out of 10. But what the researchers also told us in the UK is that we miss half of those children. We don't even know half of the children who should get a diagnosis because we don't even diagnose them until after the age of 16. So our teachers are not identifying half of the children who have learning differences or learning difficulties. If these are our education experts, why can they not identify children who have learning impairments? And again, when they do, often it is about a negative deficit-based perspective on what children can't do rather than what they can do. So challenging stigma will improve access to services and will improve the quality and effectiveness of services. But what we need to do most definitely is take a systemic approach across home, school, and in healthcare settings, and educate teachers to understand that learning is a social process. They need to understand the neuroscience of learning, and they need to recognize that you cannot just assume that because a child has ADHD, that they will underachieve at school. And part of all of that as well is I have very serious concerns about things like Conno's questionnaires, which are observational rating scales that rely on a very subjective opinion of a teacher who might have a very outdated view of what represents context-appropriate behavior in a classroom. And we know that things like anxiety disorder can look like ADHD, but it isn't. In the UK, nearly half of all children referred for a diagnosis do not have ADHD. So half of the children we're having assessed don't have ADHD, but we're missing half of the children with ADHD, and we're not finding out about them till after they're 16. Raises very serious questions for our education workforce. So we're insisting now that schools are using computer-based cognitive functioning tests to help assess whether or not there is a cognitive impairment in the child's brain, rather than just relying on one teacher's personal view about whether a child is behaving appropriately in a classroom. And getting teachers to understand that ADHD is not a behavioral disorder, but a neurodevelopmental condition. And of course, children are going to present behaviorally because they don't have the self-awareness, the maturity, or the language to actually communicate effectively why they are experiencing difficulty with learning in schools. So again, more sophisticated measures to quantify accurately what the brain functioning is. It's very simple. This can be done by teachers. It doesn't need to be done by clinicians. And now in England, we have a national strategy that is going to be about making training available for family doctors, so you don't have to go to a psychiatrist to get a diagnosis, unless you have complex comorbidity. that family doctors can do more to treat and support non-complex ADHD, that schools are better trained, that parents are given training, and that every school runs a training program for parents, and that we only use specialist consultants when there is complex comorbidity, and that we make sure that we begin to plan for transition from children's services to adult services from about the age of 14. So that transition happens over a period of time in order for it to be successful. But most importantly, because young people, when they're leaving school, do not want to go and see a psychiatrist because they do not see themselves as mentally ill. But because often this ADHD label is seen as a psychiatric problem, then there are lots of young people who on leaving school do not want to be identified that way. So we have to destigmatize it ourselves. And, by doing so, improve access to patient care and to reduce the risks, not just to mental health, but we know that there are correlations between increased blood pressure, risk of stroke, eating disorders, obesity. Obesity obviously then increases the risk of type 2 diabetes, and also reducing the cost of social and economic dependency, because a lot of our young people with ADHD fail at school, and that will impact on their life chances in terms of their career and earning capacity. So again, for us, a neurodiversity agenda is really quite important as a way of tackling stigma and improving access to health and education that is appropriate for children, because we have to agree and understand that for many children and young people and for adults, their experience of education and sometimes their experience of health services is traumatic in itself. And there needs to be a cultural shift if we're going to address some of these issues. And thankfully now there are lots of MPs, lots of members of Parliament in the UK who are meeting on a regular basis now to address this issue. Finally, the voice of the public has been heard, not because a psychiatrist has produced a brilliant research paper, but because the politicians have actually begun to hear from the people that they want this issue to be taken seriously, but they want it to be seen in the context of the 21st century and in a much more patient-centered way.
Okay, thank you very much, Dr. Lloyd. That was really a great talk. And we already have some questions from the psychiatrist part.
Okay.
So it's Nadia Maric from...
Can you stop, Tony, can you stop sharing your screen?
Yes, you did.
I have.
Okay.
So, Dr. Maric asks you, Dr. Lloyd, the prevalence data are really high. She says, what was the population where 1 out of 20 has ADHD and 1 out of 100 has Tourette? Is it a general population or some specific population?
This is World Health Organization data. It's not location specific. So we know, for example, in the United States, it's 11%, which is extraordinary. But in the UK, diagnostic prevalence is 2.9%. World Health Organization says it's 5.26%. But interestingly, in the UK, nearly half of all new diagnoses are for adults, not children.